My capstone is entitled Strengthening the Therapeutic Milieu for Youth in Residential Care. This is implementing a caregiver-focused intervention in clinical treatment. So we know that the therapeutic milieu really is strongest when all disciplines are working together. Yet for youth in residential care, we often see that caregivers have only a minimal role, if a role at all. As a result, many of our long-term goals go unmet, and often this leads to youth being readmitted into residential settings. In addition, those successes that we do see while they are in placement, such as learning new skills and techniques to cope with their emotional, behavioral, and mental health needs, cannot be generalized once they return home. This happens because caregivers are not taught how to carry on with those same practices that those youth come so much to rely on. And since the treatment really does focus specifically on the youth's needs while they are in residential care, little attention is given to teaching clinicians how to prepare for the challenges that the youth are going to experience post-discharge. In other words, the clinicians are not being trained in any family-based interventions. Instead, their contact with caregivers is really confined to simply using them as information sources or able to report out on child success while they are in treatment. So what we wanted to do was bring an evidence-based model into the practice that we are already providing. So what we had chosen was the Therapeutic Crisis Intervention with Families, the TCIF, training for the trainers. So this model was identified as a way to further bring caregivers into the milieu. So TCI was developed by the Residential Child Care Project at Cornell University back in 1980. So it's been around a while. There's been many adaptations to it, including an adaptation which includes training for families. However, that training really specifically focuses on foster families rather than caregivers, but that was part of really what our adaptations were later on. I'll get to. One more thing about that. So one thing that I do want to just point out, just in terms of the model itself, really does focus on trauma, and all of our youth in residential care really have experienced trauma, not only from their experiences prior to getting to us, but just the separation from their families in itself is a trauma that they do experience. And we see, and this has really been ingrained into all the sports and all the services that are part of our facility, that the trauma that all individuals receive really does impact the way that they experience their realities. So what this TCI is intended to really teach a safe way to manage any aggressive or violent behaviors that demonstrate as a result of those traumatic events. And what we do is intervene in order to repeat those, prevent those negative patterns from repeating, and really work to improve and develop a safe, trusting, and supportive environment for these youth. So although we've implemented other strategies and other models at Little Flower, this one was different because we did approach it from using the application of implementation science. So here, a deliberate and systematic approach was used to identify those barriers, facilitators, and really identify what strategies were needed to support implementation. This helped to ensure a successful uptake of TCIF at Little Flower. For this project, the COM-B was used, so we've kind of gone through that. So I don't know if I want to keep repeating it, but really what this means is that we focus on the behavioral changes, really needing to take focus on incorporating what needs to change, what changes need to happen, and what we as individuals need to do to push those barriers away so those changes can happen. So Little Flower RTC, another really focus on the longevity of our facility, has been around since the 1930s. So right now we have about 80 residential youth between the ages of 8 and 23 years old. And they're placed by the Department of Social Services or local community school districts. Really what we intend to do is focus on supporting those developmental, behavioral, emotional needs specific to autism spectrum, developmental disabilities, as well as mental health disorders. I often explain to other people that the youth that we have are pretty much akin to the youth that we would see in a hospital setting, just at a different phase in their treatment. So we use the theoretical domains framework, or the TDF, to systematically and comprehensively review the theory derived from our process. And that was done to identify these barriers and facilitators. This allowed us to determine what facilitators we could influence or obstruct our behavioral change. In doing so, several individual level barriers were realized, including clinicians' perceived lack of knowledge of the TCI model, specific to the use of caregivers, requiring the skills that they needed to teach that model to caregivers, and having limited confidence in their abilities to implement an intervention in this setting. In addition, there was concern that energy needed to move forward with the new treatment modality may exhaust resources already being used, or resources that could be better used elsewhere. What we did have going in our favor were that these facilitators, including clinicians' understanding of the TCI model. So prior to this implementation, 2 of our clinicians had already been trained and certified as associate TCI instructors. And all 7 clinicians involved in this project had been certified in TCI. This proved to be very valuable as we saw the fundamental features of the TCI model already embedded in the Milieu. Making it known to clinicians, the residential staff, the youth, however, very clearly excluding the one component of the caregivers. In addition, we also found some contextual level barriers. Here, several did emerge. Most notably, we're also referring to just the conditions that we were in during the pandemic. So as we were really going through this project, a lot of our efforts were really focused to shift on those needs in the most pressing needs at that time. So as we had emerging issues, we had emerging needs, obviously. What we did have going in our favor on that much grander scale was the support from all of our stakeholders. Everybody from our senior administration to the clinicians taking part in the implementation. This excitement and willingness to advance the project was really one of the most valuable things we had going for us. Everybody really seemed to get on board, number one, and was excited about being able to implement something new. So to help support this implementation, these key implementation strategies were used. And these were developed using the TDF, in addition to the Consolidated Framework for Implementation and Research, or the CFR, to allow a thorough and analytical approach to understanding conditions faced during implementation. These barriers identified using the TDF and CFR were matched to the expert recommendations for implementing change for the Erik model, not different. This approach helped to determine clinicians at Little Flower RTC needed to do differently to overcome implementation barriers to teaching the TCI model to caregivers. Specific strategies that relied on to support the implementation included providing clinical supervision, conducting local consensus discussions involving patients and consumers, and accessing new funding and revising those professional roles. So our findings really focused on the clinical reporting for the knowledge, skill, confidence, appropriateness of the intervention, and the adoption of the model itself. Although they could not be considered statistically significant, they were, however, clinically significant. What we're able to see that for each of these categories, with the exception of knowledge, that clinical reporting between the pre-implementation and post-implementation did increase. This helped to, this is what we had hoped for, and also was anticipated as we identified the strategies to implement this change. In addition, we found that 67% of clinicians received the targeted amount of supervision and 33% received 3 supervisions. What this means is that all clinicians received at least 3 of the 4 planned clinical supervisions during implementation. Also, a thorough review of agency publication, including internal newsletter, social media, and agency brochures, identified TCI with families mentioned only 1 time throughout the project. This was in contrast to the 4 other evidence-based models currently being used at Little Flower, which were mentioned a total of 5 times. We were able to allocate funding in the 2023 annual budget. However, we didn't use that funding because of the training opportunities that not being available to us due to the COVID-19 pandemic. I'll get into how we overcame that in a second. And then finally, review of our initiative of our internal records, including job descriptions, performance evaluations, did indicate that the TCI with families was added as clinical expectations and part of treatment as usual. So for those adaptations, a big part, and I'll skip to the bottom first, is that implementation. Because of the COVID-19 pandemic, we were not able to use the training resources that were available to us because they had shut down. So as a result, we were forced to modify the way that we delivered the intervention, and instead that was done in-house through our people who had knowledge of the TCI model and training of the TCI model. The other big thing in terms of the intervention, as I mentioned before, the TCIF model does focus on professional foster parents who have really received other training and other understanding of how to care for youth with specific special or exceptional needs. So what we did is we took that model and we applied it to caregivers who haven't had prior training and may have not really received any training at all regarding the care of their children. So this was a significant change and something that really was necessary and needed in terms of the intervention itself. In terms of our key takeaways, throughout this project, there was a critical supervision really did emerge as the essential component to implementation and the success of the intervention itself. Clinical supervision provided an opportunity to discuss challenges, celebrate our successes, and reinforce the fidelity of the model itself. It was also realized early on that multiple stakeholders were eager to take on the challenges to aid in implementation. These individuals were found on every level, from the direct practice to senior care administration. Yet we can't overlook the impact of the strong interpersonal relationships on the ease of implementation itself, which may in itself make it difficult to replicate this at other places where that relationship and those partnerships aren't as strong. In addition, we also saw caregivers themselves joining in the collaboration to reinforce the goals and joining the practice itself. Their support and efforts really gave us a new understanding of how much it was needed and also how much it was willing to be accepted. Notably, caregivers feel grateful to have additional support, attention, and really were able to learn the tools needed to care for their youth. In the end, the project really demonstrated the use of implementation science and how it can be used in a residential setting. While other clinical interventions have been tried, none of them had been more deliberate and methodical than an approach used in implementation science. Ultimately, this approach enabled us to enable the application of a much needed evidence-based model to the specific setting, service recipients, and accounted for the realities of the practice itself. This project also gave us the ability to demonstrate what efforts could be taken to close the gap between research and clinical practice. It is anticipated that this approach can be applied to other evidence-based models in order to further services available to Little Flower. And in addition, it can be a model that can be used in future practices and future products throughout